And we have two gentlemen joining us now. It's Dr. Anil Kapoor and Dr. Ali Khan Lalani. I am so grateful that you gentlemen are here today and going to share information on very important topics. And if you two don't mind, I'm going to give you a very brief introduction and then I'll let you take it away. So Dr. Anil Kapoor is currently Professor of Surgery, Urology, and Oncology at McMaster University and St. Joseph's Hospital in Hamilton. He is current Director of the Urologic Cancer Center for Research and Innovation at St. Joseph's and head of the Genitourinary Oncology Program at the Jarovinsky Cancer Center. He's co-chair of the NCIC Kidney Cancer Disease Group and chair of our Kidney Cancer Research Network of Canada. Also co-vice chair of Kidney Cancer Canada, so he's no matter what. He's currently head of the clinical trials group at the McMaster Institute of Urology and established the Kidney Cancer Center at McMaster University in 2009. Thank you, Dr. Kapoor, for joining us today. And Dr. Ali Khan Lalani is an assistant professor at McMaster University and a medical oncologist at the Jarovinsky Cancer Center. Dr. Lalani had his fellowship in genitourinary oncology at the Dana-Farber Cancer Institute in Boston, mentored by Dr. Tony Shueri, and completed the program in clinical trial effectiveness, I'm trying to rush, at Harvard T.H. Chan School of Public Health. He's a member of the Escarpment Cancer Research Institute, an associate member of Center for Discovery and Cancer Research at McMaster University. Dr. Lalani is interested in clinical trial design and translational work, and it was awarded the Elizabeth Eisenhower Early Drug Development Young Investigator Award in 2022 and is lead PI for the CytoShrink clinical trial. Thank you both for joining us today. You're going to be speaking on insights on early stage RCC detection and emerging management strategies, and we look forward to the information that you're going to share with us today.
Thanks so much, Christine. That was great. Great introduction. I appreciate it. And can you hear me okay?
I can hear you just fine. Thank you.
Wonderful. Well, it's great to be here. And Dr. Lalani and I are going to talk about early stage kidney cancer and basically localized kidney cancer is a better word probably. And once localized cancer has been removed, that's the highest cure rate, but there's a degree of reoccurrence. And the reoccurrence rate is very low if it's a small tumor, but it's a bit higher as the tumors get bigger and are of higher grade. And now we have some strategies that we can offer patients in the adjuvant setting that are approved in Canada. And then the question is, who's the right patient for that adjuvant therapy? And we can have some discussion about that. Let's start. So I'm at McMaster University with Dr. Lalani. One of the biggest accomplishments we've had in Hamilton is to capture Dr. Lalani to our center. He's really a superstar and done some amazing work in kidney cancer and GU cancers. And so we're very proud of his trajectory. These are disclosures for today's talk. So in terms of localized kidney cancer, it's the 7th most common cancer in men and the 10th most common cancer in women. In 2018, it was estimated that almost 500,000 individuals per year are diagnosed with kidney cancer. 80% of all kidney cancers are what's called renal cell carcinoma, and the renal cell carcinomas can be divided up into a clear cell or non-clear cell histology. Clear cell is the majority of those, and then the non-clear cell includes papillary type 1, papillary type 2, chromophobe, then the variants as well. So most of the time we diagnose kidney cancer when it's asymptomatic, and it's often picked up due to incidental abdominal imaging, where somebody has a gallbladder pain or kidney stone pain and they have an ultrasound showing a mass in their kidney. And this leads to early detection and cure because we're able to capture before it's able to spread to other parts of the body. Unfortunately, though, still there's a percentage of patients, about 17%, that present with their tumor having metastases. And that's where it's already spread to stage 4. And then we offer the systemic therapies, and we have lectures in the session today talking about systemic therapies that are very, very effective now, up to 1 and 2 out of 10 cure rates even, with some fantastic new drugs that we can offer. So we'll leave that for the other talks. But in terms of for the small or localized renal masses, first we often get an ultrasound, and then we'll do a CT or MRI. Angiography is not as much used nowadays, but really with ultrasensitive CT and MRI, that's our gold standard to identify the mass and stage it. So we really want to stage it by seeing where it's gone. If it's just in the kidney, then it's curable with local interventions such as surgery, probe ablation, cryoablation, RFA. Surgery is the gold standard. And also we'll consider a biopsy to establish a tissue diagnosis, because it does help us determine if the cancer or the tumor is benign or not. And I say that because tumors that are less than 7 centimeters, there can be a significant percentage that are not cancerous. So if you have a 4-centimeter tumor or less, about 25% of those tumors can be what's called oncocytoma, or it can be angiomyolipoma, or other benign pathologies that don't require any surgery, because those pathologies do not spread. So for smaller tumors, we often do biopsy these lesions to get us to see if they're in the 75% that are cancerous or 25% that are not cancerous, and just reassurances to our patients. So then the imaging, again, we talked about the CT scan, MRI. We often just do a CT scan of the chest, abdomen, pelvis, rather than a chest X-ray and then a CT abdomen, pelvis. But those are certainly options. Bone scan if there's high risk for bone metastases. And PET scanning hasn't really come into favor as yet, as other than a research tool for kidney cancer. We have questions quite often about doing a PET scan for kidney cancer, but right now in Canada, at least, it's more of a research tool. We're just still trying to define the right patient that would benefit from the imaging of PET scanning. And right now, your urologist would probably just do a CT scan and a bone scan, which gives you a very, very good information about staging and where the cancer has gone. And hopefully it hasn't gone anywhere. If it's just localized to the kidney, then we call that stage 1. That's less than 7 centimeters. We use what's called a TNM staging. T stands for tumor size, N stands for nodal status, M stands for whether it's metastasized or not. If it's a T1, it's a T1A is less than 4 centimeters. If it's between 4 and 7 centimeters, it's T1B. Well, those are still localized non-metastatic tumors, T1. If it's T2, it's over 7 centimeters, and you can have T2A, which is between 7 and 10, and T2B is over 10 centimeters. T3 is when the tumor has gone into the vein. So T3A is into the renal vein, T3B is into the vena cava below the diaphragm, T3C is above the diaphragm, and T4 is when the cancer is pushing the organs around it and into the adrenal gland or other organs around that. Now, this is important because this will help us determine the risk of reoccurrence after surgery. We're going to go into more details about that, but the risk of reoccurrence for a T1, as you can imagine, less than 4 centimeters is very low. The cure rate's over 95%. Whereas if it's a T3, the risk of reoccurrence is higher. And when we counsel our patients after surgery, we need to be a bit more precise about these numbers, because now we have options to offer patients after surgery. So as we get into this, the treatment for localized cancer, again, is mainly surgery. That's the best cure. But for patients that are high surgical candidates, there are still other options such as RFA, cryoablation, thermoablation, or even SBRT radiotherapy ablation. So the left side here, for localized 1, 2, and 3, any size of treatment is partial nephrectomy if possible. If it's not possible because it's into the renal vein or too large, then a radical nephrectomy, as long as the other side is okay. And then again, for the small mass for patients that are high risk for surgery, RFA, which burns the tumor, cryoablation, which freezes the tumor, thermoablation, which also thermoablates the tumor, or radiation is another technology that we can offer patients for localized tumors. Now, advanced disease is a whole separate lecture in itself about the primary disease. It's called the cytoreductive nephrectomy. That is, when our patients have the tumor in place and they have spread the cancer to the kidney, beyond the kidney to the liver or lung, then that's stage 4 metastatic cancer. And in general, taking out the kidney would not cure it because the other spots of cancer still remain. But we have some data saying that if you take out the kidney, it may help you with some of the drugs that we can offer in certain select patients. And again, we can have some discussion about that at the end if we have some time. But the other thing to consider is taking out the kidney and the spot that may be in other places, such as the lung or the liver. For example, if there's a single lung spot and the kidney's in place, if you take out the kidney spot and the lung spot, you could potentially cure our patient by removing those two spots. And I think that's very, very important by resecting that with surgery of the kidney and that what's called the metastatectomy of the lung spot or liver spot. Those are still high risk for recurrence. And that's where Dr. Lalani is going to talk about a drug therapy we can offer after those higher risk patients. But certainly that's something we can consider is nephrectomy plus metastatectomy in those patients. Partial nephrectomy, the way we do these is we clamp the artery in the vein and then we excise the tumor, put it back together again and preserve the kidney, called nephron sparing surgery if at all possible. Now, it's important to understand that if your urologist or your surgeon says, I'm going to take out the kidney, all of it because that's the best thing to do, even though it's only a small mass, it may be because of many factors, such as especially the location of the mass. If the mass is very central in the middle of the kidney, by the artery in the vein, maybe a partial nephrectomy is not possible, even though it's a small tumor. That's a sign of wisdom where you're taking out the kidney to preserve your margin, taking out all the cancer, decreasing your risk of reoccurrence, which is really paramount to take the cancer out with a negative margin as opposed to leaving any cancer behind. So we try to do partial nephrectomy, but in some patients, a radical nephrectomy is necessary if it's a central tumor, if it's into the renal vein or IVC thrombus, into the adrenal gland, and other factors can be considered with your urologist. So then after the surgery, everything goes well, then your urologist tells you about your pathology, and then you have to talk about your risk of reoccurrence. And I think this is where we now need to be more precise about that discussion. In the past, because we had no adjuvant option, we would tell patients, we've got all the cancer, we're going to do your CT scan or bone scan, chest x-ray, ultrasound in 6 to 12 months, and we'll see you then. But now that there's an option to offer patients or options, then we need to know the exact precise percentage of reoccurrence. And that's important after these surgeries, and it's based upon two major factors: the stage of the cancer and the grade of the cancer. The stage of the cancer is where the cancer is gone. If it's just a 2-centimeter tumor, the risk of reoccurrence is very low. So perhaps not giving a drug afterwards wouldn't make a lot of sense because of the risk of the drug versus the risk of reoccurrence. Whereas if somebody has a large mass and the risk of reoccurrence is higher and the grade of the tumor is higher, it makes sense to offer an adjuvant drug to decrease the risk of the cancer coming back. So we have certain models that help us to do this. And again, in the past, we would sort of say, it doesn't actually matter what the risk of recurrence is because we have nothing we can offer you. But now that's changed as of this year. And so knowing that risk of reoccurrence is important for patients to understand it, to see if they want to take that drug to decrease the risk of reoccurrence versus not taking the drug based upon that percentage. So T1, we talked about that. That was less than 7 centimeters. T1A is less than 4. T1B is less than 7. Intermediate risk, T2, is over 7. T2B is over 10 centimeters. High risk T3, T4 is into the renal vein, and your risk of reoccurrence is higher as the stage is higher. So less than 7%, 95% cure rate for T1. For intermediate risk, you're up to 16 to 35% can develop reoccurrences at 5 years. And T3 is the highest risk. If the tumor is into the renal vein or into the renal sinus, and keeping with T3A, up to half of patients can have reoccurrence within 2 to 5 years. And so those are patients that may benefit from this drug after surgery to decrease that high number. So we have these guidelines that we follow to help us determine the risk of reoccurrence. And this is the algorithm that we follow with the CT scan, chest x-rays, ultrasounds after surgery to counsel patients about your risk of reoccurrence. And most of the time, for localized small masses, the cure rate's very high. But for higher grade tumors and bigger masses, the risk of reoccurrence is higher, and that's where we need to be more rigorous about that. And you can see the bottom of this graph, very high risk. We follow much more aggressively with CT scan imaging much more often to keep an eye on any reoccurrence as soon as it happens to offer some intervention. So how can we look at the risk of reoccurrence, and what are the treatment plans we use for each stage of this kidney cancer? So these are tools that urologists should be aware of, and you should ask your urologist after surgery, what is my exact risk of reoccurrence? And we have these, what's called nomograms. There's 3 of them. There's the Leibovitz, there's the S sign, and one other, and we can use these to help us quantify this. So you can see your assigned points based upon the size of the tumor. You're assigned points based upon the aggressiveness of the tumor, the grade of the tumor. And then you add these together based upon the size and grade. And then if you're in these risk groups of low risk, your cure rates are in the 95% plus, which is fantastic. But if you're in the high risk, if you have a larger tumor and higher grade, your risk of reoccurrence is much higher. And that's where we need to have some very aggressive follow-up and discuss options to decrease the risk of reoccurrence. This is the S sign score. This is the second one that we sometimes offer patients to look at nomograms. And these are very similar in terms of their numbers, but the urologist should use one of these 3 at least to quantify the risk of reoccurrence. And again, in general, if it's a T3 high-grade tumor, the risk of reoccurrence is about 50% at 5 years, which is quite high. The last one I'm going to touch on is what's called the UISS model, which is a California model, which again touches on the grade of the tumor, the size of the tumor, the nodal status, and also the performance status of our patient if they're robust or not as robust from the tumor. And then we use these risks of reoccurrence, which are very similar to the other nomograms. If you look at localized disease at the bottom, the high risk group, 50% risk of reoccurrence at 5 years. This is kind of the theme that we see for these higher risk tumors that we're so glad that we can offer an option now to consider for those groups of patients. So with that, I'm going to pass it on to Dr. Lalani, who's going to talk about some of these options that we can offer.
Thanks so much, Dr. Kapoor. That was great, and important to highlight the curative intent of surgery and how folks are followed. We're going to shift a little bit about what can be done in addition to surgery or after surgery, and this is called adjuvant therapy. And the field has also tried to understand, well, could something be done before surgery, which is a so-called neoadjuvant or prior to surgery type treatment. So we'll cover these and hopefully by the end share where the state of the union is once you have a surgery for your kidney cancer. So let's just briefly summarize neoadjuvant therapy. This is treatment that would be done for a localized kidney cancer to hopefully reduce the size of the tumor where it invades. And maybe that could somehow help a subsequent surgery and ultimately reduce the chance of this cancer coming back. It sounds very plausible and is used in a variety of cancers, breast cancer, colon cancer, others. So why not think about this in RCC or kidney cancer? So some of the benefits are that, hey, if you can shrink a tumor, maybe a nephron sparing surgery or a surgery that preserves more of that kidney is possible. Perhaps it gives you a sense of how a tumor will even just respond to systemic treatment. And altogether, maybe this can help improve surgical outcomes and indeed a patient's long-term overall survival. Some of the challenges in theory when you study this in clinical trials is, does it delay definitive therapy, meaning doing some form of systemic treatment first and then going on to surgery? That's a risk. Perhaps some of the treatments that could be used, like our anti-angiogenic or targeted therapies, TKIs, you might have heard these words used before for drugs in that class. Maybe that could somehow impair the healing that one needs for a surgery. And if you use it up front, will the body remember that and somehow get a little bit more resistant to it later? These are some of the theoretical benefits and challenges. Anytime you study neoadjuvant or treatment before your surgery for a cancer in general. So the state of the union really is that phase 2 clinical trials, these are trials that have already come from a bench into a clinical setting with some patients with many different tumors and then focused into maybe kidney cancer, but trying to understand if there's any side effects of this. They showed that actually the tumor size did reduce, but this was really experimental and further studies were needed to really confirm if, hey, this should be the gold standard, ready for prime time approach for all folks who have a kidney cancer about to undergo surgery. So it had been previously that it was really not recommended to do something prior to surgery, just get on with the surgery, get that curative intent treatment. So a phase 3 trial was conducted to try and answer this question. And I think we need to acknowledge that this was a large international effort. Many countries around the world participated in these types of studies. For example, this PROSPER phase 3 clinical trial. Canada was part of it. The Canadian Cancer Trials Group took a leadership role in bringing this trial to patients in Canada. And champions included Dr. Kapoor, who was really pivotal in ensuring that we had this trial available to advocate for our patients, to understand this question. And, really briefly, this was a phase 3 trial, meaning that it was a randomized trial that had half the patients actually get the standard of care, which is you have a cancer in the kidney, get it cut out. And the other half of patients would have gone on to have a biopsy, treatment with immunotherapy for 1 dose, surgery, and then 9 doses thereafter. So that's part of the criteria in the treatment you see on the left of the slide there. So the inclusion was non-metastatic, so not spread kidney cancer, at least size T2, or including node positive patients, which you've seen a little bit about that in Dr. Kapoor's talk, and then planned for a partial or radical nephrectomy. This is what was needed to be part of the trial. And as mentioned, 50% of the patients got some form of treatment, 1 dose of nivolumab immunotherapy prior to surgery, and then 9 doses thereafter. The other half of patients, as mentioned, went on to the standard of care, which is nephrectomy, followed by surveillance, and there was no placebo in this trial. Again, something that I think when we work with patient advocacy groups, and I think the kidney cancer community has a lot of folks to be really proud of who advocate for patients, especially at trial design stage, this really helped to ensure there was no placebo. And so part of it was to understand how safe is this? Can we do this? And is it efficacious? So on the right is kind of the summary of the readout or the presentation of this data that happened at the ESMO conference that happened in Paris this year. It's the European Society for Medical Oncology. The data was read out and displayed for everyone to see that this approach of doing 1 dose of treatment, surgery, and then doses of treatment thereafter did not improve or did not make better the chance of the cancer coming back. So the recurrence-free survival for folks who were in this trial. That doesn't mean necessarily patients were harmed. It just means it wasn't shown to be better than doing upfront surgery. I think there's lots of questions as to why a very common sense or I think appropriate design didn't play out. There's lots of technical details around this. Not all patients had tissue confirmed, meaning that you could have shown up with a CT scan that looked like a kidney cancer and then randomized in the trial. Some of these may have affected how high risk these folks were. 20% of patients didn't have clear cell kidney cancer, the most common type of kidney cancer, one that is most commonly studied. And so there's all these little pebbles along the path that might have answered why it was a study that showed a new approach would be better, but it was worth studying. It was really important to be part of, both from a country, from provinces, from centers in Canada, and obviously patients and their families to take a leap of faith to be part of these trials. So it was really important to do. So at this time, the recurrence-free survival was not approved with this approach, and the overall survival, so the lifespan of all the patients on the trial, is still undergoing evaluation. So we'll see that along the way. For those of us interested in clinical trials and in academic study of this type of approach, there's lots of important information we're still going to get. Folks would have had tissue. All patients would have generally been planned to go on to surgery. So there's tissue available, there's imaging available. Could radiomics and interesting pathomics be involved to understand, hey, what about a subgroup of patients that might have benefited, which we'll learn later. But I think there's lots of data here to try and understand. So I don't think the story is settled on these types of approaches for folks who have a local kidney cancer, but this trial was not shown to be beneficial. So the state of the union right now is that folks who can go on to have a curative intent surgery should go on to that upfront. So this was a little brief discussion about doing some form of treatment neoadjuvantly prior to your surgery. But the majority of this discussion and part of this talk is to figure out, well, let's assume now you don't waste time, you go on to a surgery. What about doing something after? That's adjuvant treatment, or treatment you can do really additively after your definitive surgery. So this slide shows what was many years of hard work, patient involvement, clinical trial design and readout all on one slide. So it's not meant to really diminish the amount of efforts that took, but I think for the purpose of time, it's really just to show that in the past, when the approach of using oral pills, targeted therapies, drugs you know and may have heard of, sunitinib, sorafenib, mTOR inhibition, still targeted therapy like everolimus, or even pazopanib and axitinib. All of these were studied because they'd been shown to help folks who have a spread cancer. Why not study it after a surgery for earlier stage folks and see if that could delay the cancer coming back? And really, you see the punchline from the top of this slide. Adjuvant treatments in the targeted therapy era, all those agents or drugs are listed there, did not show an overall survival benefit, meaning this type of approach of doing surgery and then oral pills after did not improve folks' lifespan. There was one trial at the very top, the S-TRAC trial with sunitinib, that showed a slight reduction in the risk of the cancer coming back. So this hazard ratio of being less than 1. But that was really countered by the side effects of being on that drug for these folks in that trial. And hence it was just not really felt to be a wide global standard of care. So that's why this is one slide take-home point to say doing oral pills alone after kidney cancer surgery with these agents was not recommended, but they needed to be studied. And so you can see where the field would go if you follow really just all oncology in general. If the state of the union of the oral pills has been settled after surgery, let's say that's the case, then what about all the immunotherapies, which you may have heard about already in general and earlier today? They help folks with a spread cancer. What about doing these treatments earlier after surgery? So still adjuvant therapy, but instead using IV immunotherapy, which we all, I think, have been hearing more about over time. So this slide shows that we've known now for over a year that pembrolizumab, this is IV immunotherapy, PD-1 immunotherapy or immune checkpoint inhibition or checkpoint inhibitors. You may have heard about this already today. This was the first time a phase 3 trial showed that the chance of your cancer coming back could be reduced by using some sort of treatment. So this is a big deal because we've never really had this in kidney cancer before. So what was the data that brought this even to really standard of care options? This is a one slide to try and summarize a lot of data, but it's showing that folks, and we had this in Hamilton and really throughout Canada, were enrolled in a Keynote 564 trial, which basically looked at patients who could have been randomized to get either a placebo after their surgery or to get IV immunotherapy. Again, double-blinded, meaning patients and the physicians did not know what the treatment was, but judiciously carried out treatment either way, realizing that after surgery, there was no other treatments that patients should have gotten, which is what I showed you on the previous slide. So this was again using immunotherapy with pembrolizumab versus placebo. There was 2 years of follow-up from the trial. Just under 1,000 patients around the world with clear cell kidney cancer were enrolled. Again, all of these patients had their kidney cancer removed and then randomized to IV placebo or IV pembrolizumab. And that pembrolizumab is given every 3 weeks and started within a reasonable time window after you had surgery. So this was a positive trial. And this is how we understand or display positive trials in academic medicine. So you can see at the very top, it says this drug, pembrolizumab, improved disease-free survival and overall survival. So on the left, what you see is Kaplan-Meier plots, essentially estimates along the way as you do follow-up for the chance of being disease-free. So the, I guess, turquoise-ish curve on the left, the higher one, that's the pembrolizumab representation. And that's not fuchsia, that's more like red, a little burgundy maybe. On the curve below that is a placebo. And so that showed you that the chance of being disease-free was better by intervening with pembrolizumab versus placebo in this trial. And they show some percentages here that it really does help, I think, physicians and patients to understand this. When we talk about this after surgery, you can see that the chance of being disease-free at 2 years was about 67% on the folks who got placebo. So there's still a good proportion of patients who do well with surgery alone. But that was improved by an added 11%, meaning 78% chance of being disease-free and alive after a kidney cancer surgery 2 years out from that treatment. And, you know, this incremental benefit, right, this different number, if you put this data in the breast cancer world or the colon cancer world, this would be widely adopted as a standard of care. So it's something we in the kidney cancer community, and that means all of us, those who research, treat patients with kidney cancer, importantly for this forum, patients who have kidney cancer or families who care for these folks, I think need to hear that there is now an option that can help reduce the chance of this cancer coming back. Now, one question we all have is, well, that's great. Reducing the chance of a cancer coming back is physically and psychologically super helpful and important for patients. But what about the chance of me just living longer, or what is my lifespan improvement by doing this type of treatment? So on the right, you can see it a little bit early. There's lots of squiggly lines, the censoring, meaning that these patients haven't really been followed long enough or had a long follow-up recently with an event. But essentially what it shows is that right now, overall survival looks like that pembrolizumab curve might be better than the placebo curve, but it's very early to tell. We will need longer follow-up. This is 24 months of follow-up. Kidney cancer game for folks who have had a resected disease and needs like 5-6 years of follow-up before we can really settle the score here. But you remember that other slide I showed you about other treatments? None of them improve survival. There wasn't even a hint of improvement. There's a hint here. So to be fair, we haven't settled the lifespan question yet on the right, but on the left, you can see that that has improved disease-free survival. So that's the state of the union for using adjuvant pembrolizumab immunotherapy. Now, Dr. Kapoor nicely showed you earlier that there's different risks. All patients who have their kidney cancer removed aren't all going to be at the same risk of the cancer coming back. He showed you the tumor size that's important, whether lymph nodes were involved. He's mentioned the important tools your surgeon or urologists generally will use to quantify the risk. So let's just here look at the data for across these risk groups. Intermediate high risk, these were PT2, grade 4 or T3, high risk T4 or node positive, and then M1 NED. I think you heard this description earlier, but folks who had a kidney surgery and then unfortunately had a spread or a spot elsewhere, but that was also removed. Those folks were also involved in the trial because they were made to have NED, no evaluable disease. All of these curves, as you can see, show that pembrolizumab has a better chance of being disease-free, right? Higher percentages than the placebo arm. Now, the magnitude of benefit, I think it's very obvious. You don't need to be in academic medicine to see the separation of the curves. So when you follow the totality of a curve, that's the hazard in statistical terms, you can see that the hazard ratios really improved on the far right. It still improved, so that's 0.28. So essentially, that's a 72% improvement in being disease-free. The middle one, that hazard ratio of 0.6, means a 40%, general 40% improvement across the totality of the curve. But even those with the intermediate high risk, there was still a 32% improvement in reducing the chance of the cancer coming back. So I think patients, just really the take-home point is that there's something new in this kidney cancer game that can help folks after surgery, and patients need to hear about this. This will take time. You know, we have the time today to really cover surgery, risk scores, and everything in some nice, calm detail on a Sunday. But in a clinic, this does take time, and there's lots of questions that patients will have. And it's why we do take time with patients in this scenario, because it does need some nuanced discussion. But I think you at least can see that pembrolizumab shows an improvement in being disease-free and reducing the chance of recurrence. Now, there's other things on the pathology report Dr. Kapoor mentioned earlier that doctors look at, so urologists, medical oncologists, that are important. We talked a little bit about the T stage or the size, are lymph nodes involved. What I like to describe as the sprinkling on the cancer, meaning that there are some features that we see that are adverse, meaning they may not be the best thing to have. This includes in kidney cancer sarcomatoid features. This should really be on pathology reports in general when kidney cancers are removed. So having sarcomatoid features is a poor prognostic sign in kidney cancer, but these are generally felt to be more sensitive to immunotherapy. So not a great sprinkle to have on the cancer, but it might give us hints to say it's more sensitive to responding to immunotherapy, which in that sense is a good thing. So this trial was able to study if sarcomatoid features being present or absent was helpful. And you can see that if you had these poor features, but they were more sensitive to immunotherapy, the separation of the curve, the improvement with pembrolizumab was even better. But even if features like these weren't present on those patients in the trial who had these cancer surgeries, there was still an improvement. The curve was still better. The chance of being disease-free was still better by having pembrolizumab over the placebo. So that was an important thing to understand. So really, I think the take home is that the immunotherapy with pembrolizumab improves disease-free survival. Now, at what cost? A couple things. So grade 3 to 5 treatment-related adverse events, these are generally terms we use when we code. For those of us who do a lot of clinical trials, adjudicate side effects patients have on these trials, highly scrutinized studies. Essentially, these are more than just minor grade 1, grade 2 toxicities or side effects. These are grade 3 or more, generally leading to hospitalization or risk to the patient's health imminently. These are higher with immunotherapy than placebo, as you might expect. Even the placebo had a 1% grade 3 to grade 5 adverse event. But this could be 1 in 5 patients. Almost 20% of patients who get this treatment could have that risk. Now, remember, pembrolizumab is widely used across the world, certainly in Western world and definitely in North America and in Canada across many cancer programs. So our experience with giving immunotherapy from a physician side, from the treatment nurses in our so-called treatment suites and all the cancer programs across the country, they have a lot of experience with recognizing side effects, but it's still an important thing to know that there's a 1 in 5 chance that there could be a grade 3 side effect. So folks need to hear that when we talk about the benefits of the treatment. Now, further follow-up was had, because I told you that was all 2-year data. They did another analysis of this at 30 months, so about 2.5 years. And again, the benefits were still improved. There was no new signal seen. So, again, showing some durability. But as I mentioned, this will still be followed up. There'll be more data coming out in 2023 to show how this data has matured over time. So that was the pembrolizumab. I'll just briefly have a one slide kind of fits all for the other trials, because you can imagine industry, physicians, patients want to know about other similar or cousin medications. It's not just about any one drug. There could be many drugs or combinations that could help. So treatments like nivolumab and ipilimumab, you might have heard about this in stage 4 kidney cancer, very helpful. This was studied earlier after surgery for early stage or localized kidney cancer. Atezolizumab, or a PD-L1 inhibitor, also IV, was also studied in a surgical setting, adjuvant treatment. Unfortunately, at that same conference that just occurred in September, it showed that the combination of nivo-ipi did not improve outcomes for folks after a kidney cancer surgery. It is still standard of care, highly effective in stage 4 disease, but it was not shown to be beneficial in folks who had the surgery first and then got some treatment after. Same thing with the atezolizumab. Now, listen, there's endless amount of talks online, publications, editorials, postulations about why this is the case, and it's hard to put it all into just a few words, but I will say this: all trials are built a bit differently. The inclusion of patients in each of these studies varied. So the risk of patients in terms of their size and their sarcomatoid features, or if they could have had resected disease, even if it spread and then be included in these trials, all varied by definition and by presence. The duration of treatment was 1 year with pembrolizumab, 1 year with atezolizumab, 6 months with the nivo-ipi study. By design, that was another difference in these trials. Perhaps using PD-L1 treatment with atezolizumab was not as good as using pembrolizumab, which is PD-1 type treatment. That's another thought out there. And, there's lots of different ideas about which drugs are really critical to give a patient who's had resected disease already. So look, it's a complicated landscape, but it is important to be fair to say that the adjuvant treatment with pembrolizumab in the Keynote 564 trial is the only study that's shown benefit. Cousin drugs like nivo-ipi or atezolizumab did not show the same benefit. There's probably patient-related reasons for this, more than drug-related reasons. There's no one answer, despite people looking for a eureka answer. It's a lot of little pebbles that might explain it, but that's the really important take-home point when folks hear about adjuvant treatment with pembrolizumab. You want to know, hey, have we reproduced this with other cousin drugs out there on the market? So this is really a summary of adjuvant trials. And again, it's not to belabor the point here, but it's really just, if you're interested in hearing more about this, is to show really where the state of the union is. So I won't go through this in detail. I'll just say that, we've tried to summarize for feasibility for physicians, but also patients if they're interested. The Keynote 564, which is pembrolizumab, we spent some time talking about this. There was an improvement in disease-free survival, not yet an answer in overall survival. The atezolizumab trial, I showed that was essentially overlapping with one, meaning not a benefit, and there was no survival benefit demonstrated. That approach of doing treatment pre and post-surgery was not found to be helpful, and using nivo-ipi in a resected or after surgery setting was also not found to be helpful. So really the only one here that is fully having all the measurements under one, meaning it does reduce the chance of the cancer coming back, was pembrolizumab at the very top. So how would you consider adjuvant therapy? How might these treatments affect what you do? This is something we can certainly talk about with some time that we have. I'll just briefly mention that this whole concept of what to do after surgery is still a studied field, and I highly recommend you or your family member is planning to undergo surgery. There's lots of trials out there occurring or still to occur, and this is just to show you that at the Juravinski Cancer Center and other places, we have lots of trials building on pembrolizumab as a backbone to understand this data better, because I don't think we've settled the score. I'm going to transition now back to Dr. Kapoor to take us through this team involvement of kidney cancer, and then we can maybe answer some questions at the end.
That was awesome, Dr. Lalani. A really a great summary of a complex field, and you've done a fantastic job summarizing the data. So I think it's important that let's see, make sure I got the right slides here. Sorry, it's important that everybody put their heads together, the entire team, and the center of the team is of course the patients, right? So the patient's at the center, and then we have the medical oncologist, we have the urologist, we have the family doctor. We also have the radiation doctor on standby as well, should be necessary for other interventions. And so, how do we help patients make a decision for adjuvant therapy? Again, it's not as straightforward as saying, okay, you should take this based upon what Dr. Lalani went over. It's a good option, but you have to remember that there are side effects to immunotherapy. And I think the recommendation is that the very highest risk patients are the ones that really would benefit from this. So it's important to get a copy of your pathology report after your surgery. That's really the most important document that you can get. And that pathology report will give you the size of the tumor and the grading and of the tumor and the stage. So it'll tell you that if it's a T3 or not. You also need your CAT scans for full staging, of course, but that will tell you if it's a T3A or T3B or a T2. And certainly if it's a T3, I think that it's highest risk for reoccurrence in those patients. And that's where I think this option of adjuvant pembrolizumab is a valuable consideration. How do we help you make that decision? It's really trying to do forums like this so that we could discuss all the data that's out there with you and make the decision about whether that's right for you. If you have some other autoimmune disease or if there's other caveats, maybe it's not the best decision. If it's and again, it's a very personal decision to make based upon this data that we've shown today. The second question here, the discussion question, is about the flow, and so the flow is the family doctors usually identify the mass or the growth in the kidney. This leads to usually the urologist after that. Urologist will do the staging. And if it's already metastatic, unfortunately, in those 17% of patients, then we send off to the medical oncologist directly. If it shows that it's not metastatic, then the next step is surgery. And then again, after the surgery, you sit down with your urologist with the pathology report. And if it's a low-grade tumor T1, then you follow through your urologist. If it's a T3 or higher, then a discussion where the urologist should refer you to medical oncology like Dr. Lalani and discuss these adjuvant options that we went over today. And I think replaying this kind of discussion that he did when it's uploaded to the Kidney Cancer website would help you look at the data and make the best decision for you. The radiation oncologist is important as well as part of the team members. With the option for metastatectomy we talked about, you could radiate a lung mass or a spot in the liver if it's there. But the main decision maker would really be your medical oncologist after the surgery. So this is the clinical trials are always important. I think there was a talk on clinical trials earlier, and that is very, very important to enroll into clinical trials. Access to first-line metastatic treatment depends on many things. And this is a discussion that we're going to have with Dr. Lalani. I think Deb has asked a question here. Could Dr. Lalani touch upon how whether a patient dose adjuvant I will affect their first, second, and third line options? The answer is yes. And that's the second bullet point here. And the nuance of what this is asking is if somebody has adjuvant pembrolizumab and they develop metastatic disease on the drug, then what's the next step? And if somebody develops metastatic disease a couple of years after adjuvant pembrolizumab, what's the next step? And I'm going to ask Dr. Lalani to maybe give us some comments on that.
Sure, happy to, and thanks, Deb, for that great question, because it's important. And just to frame it for patients, we think about this when we wear hats in the patient advocacy piece, when drugs are reviewed at Health Canada, CADIT, or even within individual provinces. there's a lot of us who think around this and try and advise and advocate that we don't lose options for patients later. But so I would start by saying I think it's really important, if you're thinking about a treatment after surgery, or even if you had it, let's say in the future, and then you are being reassessed or family members being reassessed for unfortunately recurrent disease, to really ask clearly to the physician, how does my treatment I'm about to go on or did go on, does that affect what I'm about to get? So I think really briefly, and this is undergoing kind of review nationally right now, if a patient receives and takes adjuvant immunotherapy, which again, as Dr. Kapoor mentioned, is a patient and family and physician discussion, I think most of us agree those at the highest risk. I showed you those curves. The ones that had the widest separation are probably the ones where there's a bigger benefit. If folks have treatment, we are wanting to see folks able to get treatment, be safe, complete the treatment, and then be followed. I think if folks unfortunately have their cancer come back on treatment, or within 6 months of completing treatment, that in itself signals a pretty aggressive biology, right? Effective immunotherapy wasn't able to keep the cancer at bay through no fault of the patient. That's where we need to switch gears and look at something different. And generally that's going to be treatment like a TKI, stuff you would use after immunotherapy, single agent treatments we have used in the past. So again, I think the take home is that if folks are on adjuvant treatment or it recurs within 6 months, it's time to move on to something else. Now, where that becomes a bit interesting is, what about folks who don't have the cancer come back and they successfully get the adjuvant treatment, and then, God forbid, the cancer would come back after 6 months? So again, let's say you were to have treatment, as Dr. Kapoor mentioned, it were to come back 2 years later. In that situation, we're trying to advocate, and I believe most provinces will adopt this generally and widely throughout Canada, that if your cancer were to come back after 6 months of completing this treatment, the clock would be reset and the whole toolbox would be open to a patient in the stage 4 setting if the cancer were to come back. So that means no doors are closed, treatment is widely available. I think this slide does a good job of pointing out that all of us who treat kidney cancer will always look at a patient and say, first of all, what is the prognostic score? Where's the burden of disease? If it's just one spot that's returned, a couple, could surgery or radiation be leveraged? And if systemic treatment is needed, we would look at if adjuvant treatment was given in the past and then evaluate the metastatic treatment after. So that's how I would think about it. But to go back to the question, yes, if a cancer were to recur while on immunotherapy or just 6 months after completing it, that would essentially move out of the immunotherapy landscape and then go on to just TKIs thereafter, which again may still be beneficial. But I think personally, and Dr. Kapoor, I'm open to your thoughts, I think if someone is recurring while on effective drug like immunotherapy, there is something aggressive there that does need to be treated with a different type of treatment.
Yeah, 100% agree. I think that's a great summary. And we are now in the process as an organization to give some feedback to CADITH about what to do with this particular question. For example, to summarize it, if the recurrence happens while you're on therapy, then the immunotherapy is just not working. So then you need to go on another drug such as the TKI, and TKIs would include sunitinib, pazopanib, cabozantinib, or axitinib. One of those drugs would be an offer, or lenvatinib would be an offer for patients who have not had progression on their pembrolizumab. But again, if you've had your progression, if the cancer unfortunately comes back after 6 months, then it resets the whole, I like that word, toolbox, where everything is open, which would include an IO, a TKI, or an IO, such as Ipi/Nivo, to effectively treat you as a de novo patient with metastatic disease. And so I 100% agree, and that's what we're going to put forth as options for CADITH. The question is what TKI to offer. If you're on pembrolizumab and then you have progression, which of those 4 drugs? We don't really know which one is the best one. They're all very, very good drugs. And if you reoccur after a couple of years or after 6 months to longer than that, then IO-TKI would be a very good option. If you're favorable risk and intermediate poor risk, ipi-nivo with an IO-TKI are also very good options. So that's a good discussion. Great question, Deb. As always, we expect nothing but good questions from Deb. So this is our last slide. Postoperative surveillance should be adapted based on calculated risk of reoccurrence. And I think this is important. Again, in the old days, when I was younger, we would just sort of say, your cancer is gone. We're going to see you as per these guidelines, so the CT scan or ultrasound every so often, go home and have a beer. There's nothing else we can do. But now we can do something. And so that calculated risk is very, very important. Pembrolizumab is available through the compassionate use program at Merck and should be approved through funded mechanisms as well very shortly. It does show improved disease-free survival. This is an error in the slide. It does not show overall survival as yet, but we hope that it should in the next few years show an overall survival. Other potential adjuvant treatments are on the horizon with these other trials, and we'll see what they show with bated breath. And again, it's very, very important that we all discuss together in a multidisciplinary approach where after the surgery, we give Dr. Lanny a call and say, this is what we got, and this is a good patient for this kind of a therapy. What do you think? Or in either through a multidisciplinary rounds, through a formal referral, or through a discussion between urologists and medical oncologists. I think the high-risk patients should have a formal referral so that they have an in-depth discussion with the medical oncologist about these complex decisions to make together. Dr. Lanny, what are your thoughts?
No, I love that, you've summarized here how much we need to work together. And I think we're fortunate, certainly in Hamilton and the Juravinski and St. Joe's, but also in other centers across the country, that we have these conversations frequently. The referrals should be between groups that manage kidney cancer well. So I totally agree. I think that M1-NED, or certainly that higher patient population, needs to hear about this, and patients need to have the information to make an informed decision. It will take time, it will take some thought, but if those referrals come in early, it gives us the opportunity to make that decision, because it's not indefinite time after surgery, at which point immunotherapy should best be added. So, I think encouraging folks after surgery to have that pathology report discussion, ask their urologist, say, hey, my risk of the cancer coming back, is there anything else we can do? And most of us all know each other. We're a great community. We can have these conversations on your behalf, either face-to-face if preferred. I think that's great, in a tumor board or otherwise, depending on the jurisdiction you're at.
So Christine, I think that's I think we're that's the end of our last slide, I believe. Let me go to the next one, and I think it just says thank you. Yes.
Thank you.
And
well, thank you to you both. This has been exceptional information, and it is, a new and current kind of therapy that there's a lot of questions out there about, and I think you've been very helpful to our patients here today, and it will be on the website, so it will offer great reference to the patients that tune in after. I do have a quick question. I sincerely appreciate how you made it appear that this needs to be, a combined effort, with the urologist, the oncologist, and it's a very important decision to make. But you've made it sound encouraging and something not to be afraid of. At least have the discussion. And my concern is some of our patients, as you well know, are in remote and rural areas and don't have access to, this most current information in a team effort. So would you recommend that they seek out a second opinion in a cancer center where they would have, the consolidation of the urologist, the oncologist, and the current information available to them? Because it is an important decision to make on their behalf.
I'll let Dr. Lanny expand upon my answer, but in general, of course, I think the way we've seen it many times from some of the peripheral sites is they come in for their opinion, and then Dr. Lalani or Dr. Hutt, who's another one of our famous medical oncologists, would give an opinion and then give that direction to the community medical oncologist. and then they will get their care there. So
Ah.
in the defense of the community medical oncologists in the peripheral area, they're overwhelmed with multiple disease sites. They have so much work and they're overburdened, and it may not be on their radar. So having organizations like KCC have this information disseminated, the patient says, this is something I'm interested in. They come down to their local cancer center, whether it be a Juravinski or a Princess Margaret or any of these other great cancer centers across the country, get their opinion from the GU medical oncologist, and then they can have that direction back in the community site where they can access the therapy there. Dr. Lani, what are your thoughts on that?
I think that's perfectly described. It's meant to be a team effort, and Christine, just to mention, it's a two-way street as well. We're having this kind of forum conversation to educate patients who can maybe ask and seek out that opinion. But Dr. Kapoor, myself, and others are also trying to have the other communication to the community oncologists. This is what's out there for kidney cancer. This is what you need to be aware of. With that synergy of the patient asking and advocating, and those of us who kind of live and breathe and drink kidney cancer can educate our community colleagues that those two efforts can really make sure the patient gets that fulsome conversation. We're very happy to give that opinion and help guide and maintain the relationship a patient may have closer to home. It is obviously beneficial, right, to be close to home in a remote area for family reasons, for personal reasons, for a variety of things. I think folks should feel empowered that they can have the opinion, and still, ideally, if it's their choice and if it's preferred, to have their treatment closer to home.
It's already happening.
Excellent. Thank you.
I would say it's already happening. I just got a referral last week or a few weeks ago where a patient was told by the urologist they didn't need to have adjuvant therapy, and the medical oncologist said this is a good option for you, and so they came for a second opinion, and I supported, based upon the data that we have, that going on adjuvant therapy would be a good option for that patient, and they went back to their oncologist to get that done. So it's already happening, and I think again, dissemination of these kind of discussions through KCC is imperative.
Thank you. That's very encouraging. I do have a question that's come up in the chat, and it says, in the past, when initial surgery takes all tumor and kidney, full nephrectomy, and adrenal gland, I think we'll answer this generally. This isn't specific. I know who the asker is, and they're not a patient. Is there now prophylactic therapy to reduce MRCC outcomes? Is that basically, I think, what we're talking about today? But
yeah, I think you have to. Yes, there is a prophylactic therapy. This adjuvant therapy we call pembrolizumab we can offer. I guess we can expand upon this question and say that it has to be within 12 weeks of surgery, and that's a bit of a challenge in the Canadian healthcare system based upon the study. I know Deb and Bob Bick and Christine, we had some discussion whether to expand it to 16 weeks based upon the challenge, because what has to happen is you have the surgery, then you have to go over the pathology report with the urologist, then you have to book a post-operative CT scan, and then you have to go over the CAT scan, refer to the medical oncologist, and then the medical oncologist has to see the patient and initiate therapy within 12 weeks. So that's a tight, 3 months seems like a lot of time, but it's a bit tight, I think, for Canada. And I think 16 weeks would be great, but I think we're going by the trial criteria on this. I'm not sure if Dr. Lani has any other comments. I think with the discussion that we have together with our team, I know already Dr. Lani, when he hears about a patient that's a candidate for adjuvant therapy, he sees it right away. And so we really do have that collegial atmosphere with our Canadian oncology community.
Yeah, not much more to add, except I think that the whole discussion today was about this so-called insurance policy treatment that can help reduce it. And I think there was also a question about, was adjuvant therapy available 4 years ago in the chat? And just to mention that hopefully what the takeaway from our discussion was is that the immunotherapy, the adjuvant pembrolizumab, is really hot off the press in the sense that it's in the last year or two with the US approvals and then Canada and now access programs. So that's really within, I would say in Canada, more 2022 information. But prior to that, 4 or 5, 8 years ago, I think it was all trials for targeted therapy. And certainly in the last few years, there would not have been another standard of care. So hopefully folks can feel reassured if that's what that question was about.
Thank you for answering that question. I just do have one quick question, and it's a little bit aside, but there was an important question that came in previously with Dr. Coleman'sberger, and we just didn't have time, so it is for an oncologist. So either Dr. Kapoor or Dr. Lalani. The question is second-line treatment after failed immuno combo with a patient for bone metastases? They've been researching Cabo, so they wondered if Cabo would be a decent choice for a patient under these circumstances.
I'll defer that to Dr. Lalani because he's smarter and younger.
No, I don't know about that, but I'll just say, and again, not to make it patient specific, Christine, I get the tone about the question. Cabozantinib is an excellent targeted therapy, which is currently in Canada approved and used post a prior targeted therapy. So post another drug like axitinib or sunitinib or pazopanib. So I think if the question is around a potential scenario where first line treatment with pembrolizumab and axitinib, or pembrolizumab and lenvatinib in a different case, were about what to do next, I think cabozantinib is a highly effective drug and is approved in this context for this. The challenge about access is that after first line treatment, if that's what this case was asking about, with nivolumab and ipilimumab, where there's no targeted therapy in that, generally cabozantinib is really reserved after our targeted therapy is given. So therefore, another targeted agent would need to be given first to at least access by usual means, and then get cabozantinib thereafter. So that's kind of the lay of the land. And then the piece of that, which was about bone metastasis, I think that was quite the rage with cabozantinib. It became quite a part of the lexicon that is highly effective for a variety of biological reasons at places where bone spread might have occurred. And so it's certainly an effective drug for that. I don't think it's the only drug that is effective for bone metastasis, but I think it's had a lot of analysis that shows a really big benefit in hard to treat areas like bone metastasis. So if that were to be available and indicated, I think that's a very common sense option to use.
Thank you for clarifying that sequencing for us. That's very helpful. I have kind of a futuristic question, and then this will be the last one. They're looking for exotic treatments like photon therapy. Is that something that's in our future, or is that?
Well, I think photon therapy sounds really, really exciting because it's a really cool name. But I think it's not quite ready for prime time yet. The really cool thing that's going to happen is nanotechnology.
Yes.
Yeah. So you have all these technologies with nano robots that you could inject in the patient that can affect many diseases, including cardiac disease, but also cancer disease, where you can have a gene vector into a nano robot that goes straight to the cancer cell. And that's really the very exciting technology that should be coming across. So yeah, lots of exciting technologies that we're looking forward to in our lifetime that should cure cancer.
Yeah. Excellent. Thank you so much, gentlemen. I sincerely appreciate it. And I truly appreciate you putting this in language that's easy for all of us to understand, because sometimes this can be quite confusing, and I sincerely appreciate this. Has been great. So enjoy the rest of your Sunday, and thanks so much for supporting our patients and caregivers.
Thanks for having us.
Take care.
Thanks for having us. Enjoy the forum. Bye now.
Thank you.